still going to be out?
Yes, it is.
Okay. I'm just wondering if I should grab it now or later.
Up to you. It will be there still. If you want to save yourself a plate.
We're going to get going in just a couple of minutes here.
Okay, that's my cue. We still have to do our lunch. It's already March.
Dr. Sky. Dr. Sky. Paging Dr. Sky. Hi, Dr. Monica. Welcome back. Hey, can people in the back hear me? Welcome, and thank goodness we have sunshine again. It's been a dreary winter, hasn't it? So, we got sunshine. Right here in this room, all your smiling faces. It's so great to have you with us, and wonderful to have a great turnout from Mercy, including our former co-chair, Dr. Alan Erdl. Please wave. Congratulations on your retirement and your new business. And we'll be hearing about that later during announcements at the end of the meeting. We have a huge topic, really exciting moment in cardiology around really for the world right now. The number of inventions that are coming forward. If I could just ask that we not have side conversations going on while there are people at the mic, I'd really appreciate it. Joyce, welcome back. So many wonderful longtime RightCare people with us today. And a very brave Dr. Joe Sky, who's willing to dive into the, 109 pages of the new lipid guidelines. It's a wonderful step in the right direction. Lots more work to be done, and lots of new information coming out since the guidelines. So before we jump into that, we're going to hear from our chairman, Dr. Bill Baumer, who is going to get your brains revved up for this really, really important discussion. So Dr. Baumer, if you wouldn't mind teeing up a few intellectual morsels to entice the crowd.
So welcome everyone. I'm glad you were able to set your clocks forward so you got here on time. So that was part of our cognitive evaluation program for today. Today we have some exciting information related to trying to reduce residual risk of cardiovascular disease. And we would like to focus it on Sacramento. And so that's what the program is here today for that. As you remember, when we started our introduction of the year for RightCare Initiative for Sacramento, we started with this slide, a beautiful slide of Sacramento, and the river is right out here so that you are aware of it. And we went over what was literally our pledge for 2019, and that was to look at 2019 ways to live longer with the RightCare Initiative. So what I have here seems like a big list, but each of these is a proven way of reducing cardiovascular risk, mortality, and living longer. So each of these has literally a study or a trial. Many of them randomized clinical trials that show benefit from these interventions in reducing your risk of cardiovascular disease. And by doing that, you will literally live longer with that. And we focused on a couple of things that we started out with. One was the blood pressure reduction, as we went over those guidelines. And there'll be an announcement at the end about a culmination of that blood pressure guideline protocol, where we will now be issuing, or CDPH is going to be issuing actually pocket cards with the new hypertension guidelines and recommendations for it that will be going out to all of our stakeholders and institutions and primary care facilities in the Sacramento area, trying to go one step further from guidelines to actually getting in the pocket of the clinicians who are seeing these patients. And we're happy to announce that, and that was facilitated by the California Department of Public Health, and we look forward to their unveiling of this in the near future. We are here today looking at a couple of risk factors in individuals, and we're going to focus a little bit on cholesterolemia and the new guidelines for hypercholesterolemia that Dr. Joe Sky will present for us. Well, there's a lot of things that we could reduce risk shown here, so I thought rather than focus on everyone, we pick a particular patient. And so the patient I picked, shown here, is a 69-year-old male. And this 69-year-old male has type 2 diabetes, is a non-smoker, had an MI a year ago, and was recently hospitalized for heart failure. He has a blood pressure of 138 over 88, an A1C of 9.2%, and an LDL of 99 milligrams per deciliter. Currently on atorvastatin 80, the highest dose, metformin 1,000 milligrams a day, and aspirin, all of those for either diabetes control or risk reduction at this point. So the question that I have that I want you pondering on during Dr. Sky's lecture is literally what else is needed to reduce this extreme risk in this individual. So we've picked an individual at very high risk. All of us know that a number of interventions could significantly help that individual, and we're going to, at the end of Dr. Sky's presentation, ask if you have suggestions of what we could add to the ways of reducing risk besides the current medicines that this individual is on. Certainly at high risk for having an MI and death, what can we do to reduce his risk to zero as close as possible at that time? Well, with that, I would like to introduce our speaker. Dr. Joe Sky is going to focus on at least one of these issues, that is cholesterol, that is shown here, and show us ways that we can, in fact, further reduce cardiovascular disease by, in fact, focusing on cholesterol reduction. Dr. Sky is the Chief of Cardiology at David Grant with the U.S. Air Force at Travis Air Force Base. He is also closely connected to the Blue Zone. The Blue Zone is not the Blue Angels. It turns out to be better than the Blue Angels. It's an intervention type lifestyle that seems to have even greater reduction in cardiovascular disease and is associated with increased longevity that he's already presented on for that. He certainly is very interested in evidence-based medicine, but the integration of that with medicine today is certainly important, including the bringing in lifestyle and patient care, as well as the advances in cardiovascular medicine today. So with that, I'd like to introduce Dr. Joe Sky, who will be presenting on the hypercholesterolemia and its recent guidelines that have been just published. Joe.
Thank you, Bill. I'm glad to be here to discuss this topic, especially now that it's March, and so the guidelines have been out for several months, and I will get to present my thoughts after using them myself for some time now, in earnest for about a month. And I get to pick what I get to focus on, so that'll be just, I'm not going to try and teach you the new guidelines today, but over the high points. But what I want to mainly focus on are some of the highlights of the changes and how that affects us, and for the non-providers in the clinic, how it might affect the resources that our healthcare delivery systems need, and perhaps the cost as well.
Can you hear him in the back? Yeah.
I'm here as an individual. I don't represent the department. I have to read this. The U.S. government, the Department of Defense, or the Air Force. These are my own opinions. And I do have disclosures. I do work with Boston Heart Diagnostics, and I do also work with the Blue Zones as a public speaker. So today, I want to talk about what I think are the most important changes, and then we'll actually use some of the slide set from the AHA and the American Heart Association. I'm not going to use all, I think it was about 80 slides. We're going to limit it to about 19 slides of just the most important points. And then because of the significant role that coronary calcium has played in screening, especially with Victoria Dupree from No More Broken Hearts and the other efforts of RightCare members to try and initiate coronary calcium screening, I want to talk about a little bit of that history and how I think that inclusion in the new guidelines in a more prominent way is something that I think is important and a good thing. And then the next issue will be to talk about other blood tests besides the standard cholesterol panel and how I think including them in the guidelines is a step in the right direction, and how that will be something that I hope will change the way that we can increase treatment for patients that will benefit. And then, lastly, I've already mentioned it, but I think that the implementation of this is potentially going to require more resources, certainly more time from providers and potentially with patients for patients as well. So, the changes that I want you to leave today remembering, the most important one, is that lifestyle now has a major role. In all the previous guidelines for cholesterol and hypertension, it's always been emphasized. But in my opinion, the key difference in these guidelines is now that it's included as something that you monitor. And I don't think I'm going to emphasize this more than several times, but if it seems like I'm being redundant, I am. Because when you leave today, that's the one thing I want you to remember, is that lifestyle is now something that is included, but now it's part of the monitoring. Cholesterol targets are back. For anyone who was disappointed by the 2013 guidelines, that has been remedied, and cholesterol targets are back, and I think most of us agree that is a good thing. And then working towards patient goals and the use of shared decision-making. For the guidelines to include this in a robust way like they have, I think is valuable. And for people that have been doing it all along, it puts us back in the good graces of our professional societies, and in this case, the guidelines for cholesterol. And remember I mentioned I was going to talk about lifestyle and how it's important that it's now included as part of serial monitoring. The guidelines specifically address that when you monitor, you're not just monitoring the side effects of the medication, or you're not just monitoring the response to the medication, but you and the patient have discussed that when you monitor, you're actually measuring the changes that their lifestyle changes have made. And so that is something that, obviously, I'm a fan of that. And then, while guidelines recently a lot of guidelines have been emphasizing the idea of team approach, I think that if we fully carry out these new guidelines as they're written, it's essential that we're going to need to use people like pharmacists and additional educators and figure out ways to get the patient to be part of the treatment plan more so than any of the previous cholesterol guidelines. And then lastly, medications other than statins are back, and they're back in a big way, as we'll see in a few minutes, especially ezetimibe and PCSK9s. So if I could graphically show the changes between the 2013 guidelines and the 2018, it would be as follows. Most of my colleagues felt in 2013, when the guidelines came out, there were these risk calculators that were potentially flawed. There was a lot of controversy around them, and it was really just to drive a prescription for statin with a moderate or high intensity statin, and the dropping of the targets and the less focus on diet and lifestyle. Although it was still there, the focus didn't feel like it was as important. And I think that from my perspective, in the last several years, these two points have changed the way I practice more than anything else. If we look at several studies that show how healthy we are and how long we live, the data is pretty clear that the health care, or what we think of as visiting our doctor or going to the hospital, these sorts of things, it probably only makes a difference, at least on average, 20% of the time, and that it's really all the things that we do as individuals, how healthy we are, where we choose to live, and our socioeconomic status. And when researchers look at it in the opposite, on the right, if you die early, healthcare or lack of healthcare was a factor only about 10% of the time. So the new guidelines have really taken this into consideration in focusing on the fact that diet and lifestyle are so important for the vast majority of people when it comes to treating cholesterol. As we extrapolate that data for people who live a long time, they're doing things outside of the doctor's office that make the difference. And so, to me, the way that the 2018 guidelines would be represented is now we have diet and lifestyle taking a prominent role, starting with the youngest people, all the way up through even patients with significant, very high-risk disease. So Bill, the first answer to that question is that person needs to be given a lot of counseling on diet and lifestyle, and then we'll get into more details, of course. And then now the risk factor for the risks for the 2018 guidelines is more than just a calculator. I think that I use the word enhance. It's enhanced risks. There's now the ability within the new guidelines to identify risks and include the patient in those conversations to much more appropriately identify a balance between medications and diet and lifestyle, and have a more comprehensive approach to how we treat cholesterol. Some of the illustrations that the guidelines recommend that we use with our patients are things like the following. Life's Simple 7 from the American Heart Association. And I think that the guidelines did a great job of including smartphone apps, web-based apps, and teaching tools like this with very strong recommendations that we do these things for our patients. Here's another illustration of a patient handout. The guidelines were inclusive this time, in that they included things from the ACC, National Lipid Association, as well as the American Heart Association. Well, these two particular studies are not exactly in the guidelines. These are two studies that have been something I've focused on for the past couple of years. This one and the next one is when we look at when the Nurses' Health Study and the Health Profession Study were reanalyzed, 5 simple things that can make women live up to 14 years longer and men up to 12 years longer were maintaining a healthy weight, a BMI between 18 and 24, moderate or less drinking, exercising moderate to vigorously 30 minutes a day, and then never smoking, and lastly, eating a healthy diet. And the way that they defined a healthy diet was if you took 100 of the participants and had them take their tray or meal that they had prepared, and you lined everybody up and you had nutritionalists grade what was on their tray, the people in the top 40 would get a pass as being healthy. And so it's nice to see that on the 34 years of follow-up, for the people that did these 5 healthy things, the life expectancy goes out past 100. And again, the emphasis on 14 extra years for women and up to 12 extra years for men if you follow all 5 of those lifestyle and diet recommendations. And then my favorite study that has been described as being able to tell the difference between a French fry and a potato. Because we can say plant-based diets all the time, but clearly a French fry qualifies as a plant-based diet, as does a Coca-Cola and potato chips, to use another example. So I'm sorry the graphics don't show up that well, But if you ate a plant-based diet, it was healthy. But if you ate a healthy plant-based diet, it was even healthier. But if you ate an unhealthy plant-based diet, you were worse off than if you ate a standard American diet. And the other point here is that there was no upper limit to the number of servings per day for healthy foods. So if you ate healthy plant-based foods and you got a reduction in your hazard ratio for cardiovascular disease, the only limit was the fact that they only asked out to 20 servings per day on the questionnaires. So of course we don't know if you eat 30 servings of spinach a day, whether that's going to be unhealthy or even more healthy. So, but the point being that healthy foods, in looking at the same population, this was also again the health profession study and the nurses' health study, that the more healthy food you ate and the more servings per day, the more we benefited. And the way that I describe this, at the core of most of our research on diet, when you look across the studies, is something that looks like the Mediterranean food pyramid, with a focus on healthy plant-based foods at the bottom. If you add in meats and fish, focus on animals and fish that have been raised naturally in a healthy way. And then if you choose to go towards vegetarian or vegan, there's evidence that you might benefit from that as well. So looking at that as a general guideline, I think that the new cholesterol guidelines certainly made it abundantly clear that we need to be having these discussions with our patients and sending them to places where these resources can be found. And as Bill mentioned, I speak for the Blue Zones, primarily because I grew up in the Blue Zone and spent the formative years of my life at Loma Linda during medical school and early in marriage. And they have independently come to the same conclusions. When you look at the epidemiology of cities where people are healthy, where it's easy to eat healthy, exercise regularly, and practice these things, people live longer with less dementia and less cardiovascular disease. And the Blue Zones data for cities like Loma Linda show an additional 10 years or more of life with less morbidity, so less disease like stroke and heart attack and cancer.
Can you talk about that belong element before you move to the next slide?
Sure. So recognizing that this is not in the guidelines and this is from the Blue Zones, the researchers that studied the original 5 Blue Zones, when they interviewed the primarily centenarians and octogenarians and through centenarians, they looked at what they felt was the most important reasons why these people lived so long and were so healthy. And it might be a surprise to some of us that diet and exercise weren't at the base of the pyramid. So the pyramid is meant to be representational of what's the most important, the base being the most important. It turns out that food was important, but what was even more important was having friends, going to church regularly, and I think there's a study that was, I think, 2017 that showed being socially connected was almost as beneficial as not smoking, these types of things. So that's what the Blue Zones researchers found when they looked at the sense of community and belonging to a religion and going regularly with people to do organized things. Like they actually measured if you went to church 4 times a month. It didn't matter what religion, just that was beneficial. And so then diet was next, and then exercise. One of the key features of the Blue Zones data was that Loma Linda was one of the only Blue Zones where there was actually gyms. The vast majority of the other people lived in places where exercise was an essential part of your daily activity, whether it was hiking to where your garden is or where your friends are at the farmer's market or something like that. So that's why the naturally part of Move Naturally is having exercise be something that is just part of your day. So, as an aside, ever since this came out, I tell patients to do whatever it is that they enjoy for exercise. If you enjoy going to a gym, great, but if you hate every minute that you're at the gym, find something else. So before we go look at the guideline slides, I just want to take a second to look at the Lipid calculator. And I apologize, I don't know how the slide got off. Let's move it right there. So it's similar to the previous calculator, but I do like the layout a little bit better. And one of the interesting things, since this is not a live link, we can't click on it, but in this hypothetical patient, their lifetime risk is 50%, but if they optimize their risk factors, they can get down to 5%. And if you click on the real link, if you click on that, it shows you what changes they can make to get to less. And then I like the layout of the recommendations. It's in this patient's case, it's emphasize lifestyle and reduce risk factors. And of course, as with many of the new apps, we can email this to our patients or ourselves. Okay, let's take a look and go through the slides. Okay, I promised you this isn't going to be all 90 slides, it's just going to be a few. And all of these acronyms up here are a large list of collaborating associations to include cardiovascular and pulmonary rehab, the physician assistants, Black Cardiologist, American College of Preventive Medicine, American Diabetes Association, the American Geriatric Society, American Pharmacists Association. Yeah, there's a lot. And then, but I do want to point out that the National Lipid Association had an important role, and I think some of their recommendations are clearly seen in the final product.
So could you just put a fine point on that? So there were 18 specialty societies that endorsed these new guidelines, and where's the Lipid Society on that?
So these were people that actually participated in writing them.
But also calling out that I think the American Academy of Clinical Practice and the American College of Physicians, Internal Medicine Societies did not participate.
I will emphasize now that I'm going to try and focus on the positive things. I actually just realized I forgot to say that. So one of the choices I made today is there is lots of opportunity for criticism, and there is lots of opportunity for discussion. And I'm going to do my best to focus on the positive things. You make a valid point, and to that point, the most complicated part of the new guidelines is the primary prevention, of which most of it will fall to those two societies that you just pointed out, and they were not part of writing the guidelines. Yeah. So, as I emphasized earlier, we're not here to learn them, but we're going to get an orientation to the guidelines. So looking at primary prevention, I want to point out a couple of things. If you're off to the left, 0 to 19, you don't use a risk calculator. It goes straight to lifestyle. And then at ages 7 to 11 and again at 17, there's a recommendation that you draw a simple lipid panel or a non-HDL cholesterol, primarily for the purposes of identifying familial hyperlipidemia. And then if you find somebody, a pediatric patient that has a rising cholesterol level that is concerning, you can consider to do what is described as reverse cascade to look through the family members to find maybe there is a significant family history there that would warrant being addressed. So here, you don't use the risk calculator, and then at the other end, over here, you don't use the risk calculator, or the other side. So if somebody has an LDL cholesterol that is consistent with heterozygous FH, straight to treatment, diabetes, age 40 to 75, straight to treatment, possibly at a high intensity if you find additional risk factors. And then we're stuck with the more difficult patients here in the middle, where you start with the risk calculator that we talked about, and depending on whether you come up with low